continue our surgical anatomy series in our anatomy course. Today we will speak about the key to hemorrhage control internal iliac artery. Okay. Key to hemorrhage control, you are in the operating theater, horrible bleeding, you are in need for emergency ligation of internal iliac artery. So what will be the roadmap? First of all, we have to understand the origin landmark. The internal iliac artery begins at the bifurcation of the common iliac artery, typically at the level of lumbar 5, sacral 1, intervertebral disc, and the sacroiliac joint. What is the surgical landmark here? The ureter, as we explained many times before in previous videos, crosses the bifurcation of the common iliac artery anteriorly. You must identify the ureter before you look for the artery. As we can see here, internal iliac artery, and this is the ureter, and this is the ovary, and this is the superior vesical artery. It descends posteriorly into the greater sciatic foramen, as we will see in this illustration here. Again, the internal iliac artery subdivided into anterior division and posterior division with its branches, which is very important. It passing into the greater sciatic foramen, as we explained, and we can see in the illustration as we explained before. So we will start by the posterior division. It contains only 3 branches, very easy. Posterior division: iliolumbar artery, lateral sacral artery, superior gluteal artery, which is the largest branch existing above the piriformis muscle. This is an MCQ exam trap. What about the anterior division? This is the visceral division. We can say it's about 7 branches. These branches supply the pelvic organs, uterus, bladder, or rectum. Umbilical artery give up superior vesicle and then becomes the obliterated umbilical ligament. Obturator artery runs with the nerve along the lateral wall. Uterine artery, water under the bridge. The water is the ureter, the bridge is over the water. Vaginal artery supplies the vagina and the bladder base. Middle rectal artery, internal pudendal artery, main supply of the perineum. Finally, inferior gluteal artery, exit below the piriformis muscle. So this is the surgical tree, the whole tree. Again, one more again. This is the internal iliac artery, subdivided into posterior division and anterior division. Posterior division, iliolumbar artery, lateral sacral, superior gluteal. About the anterior division, about 7 branches to supply the pelvic viscera. Medial umbilical artery, superior vesical artery, obturator artery, uterine artery, vaginal artery, middle rectal, internal pudendal, finally inferior gluteal artery, which pass through the greater sciatic foramen over the piriformis muscle. What is the surgical logic here? You are in this scenario in the operating room. You have to make internal iliac artery ligation. Where to ligate? 2 centimeter distal to the bifurcation. Why 2 centimeter? To preserve posterior division branches iliolumbar. If you ligate too high, you risk devascularizing the pelvic wall and gluteal muscle. The pulse rule: after ligation, the pulse in the distal artery disappears, but the collateral circulation via ovarian and the lumbar arteries ensures the uterus does not necrose. Hoping you find this video useful. In the pinned comment, you will find a question. You can answer it and send me in private to send you a question bank for this topic. Also, subscribe in my YouTube channel for further videos and illustrations. Thank you.